Hi everybody, this is Stuart Schlossman. How are you today? I am here again from MS Views and News, Stu's Views and MS News, and I welcome you to another edition of our podcast series. This is for the date of August 25th, 2011, and attached to this podcast there is an MS Learn Online video with a very nice lady named Kate Millikan who is interviewing a doctor who will speak about the various new oral therapies. Well, not all that they're all new, but the oral therapies that we hope that will soon be available, as well as that which is currently available. Also, they'll speak about restoring function and about the Epstein-Barr virus. Now, Kate will be interviewing Dr. Brian Weinshenker on these things. Now, if you don't know anything about the MS Learn Online presentation series, it's webcasts and podcasts. Similar to the podcast that you're hearing right now, which is from me, they have their own well-orchestrated and presented videos. And this is a service that the National MS Society offers for all of those affected by multiple sclerosis. I would suggest that if you're not registered with the National MS Society, that you do get registered. And in today's video that they have a guy that speaks at the very beginning of their presentation. They have a few different people with MS who speak first before the doctor's interview. And the very, very first speaker, I have to say that I'm not happy with what he spoke about. I mean, yes, you need to know your sources. I, for one, always check my sources before I put anything onto my blog or onto my website. I hope that other bloggers do the same thing, but you know, I'm not always sure about this, and by the way that this person sounds, I guess he wasn't too sure either. So again though, MS Views and News and Stu's Views and MS News really check our sources before we provide you with any information, whether it be for this podcast series or the information that you find on our website. It's obvious by those that put their information onto our website that they know too that our information is valid. So again, listen to their presentation today. Register at their website to make sure that you get other presentations from them as they become available, or check back with me more often, because I always try to do something with their MS Learn Online series information, whether posting it here on this blog or to my Facebook page. I want everybody to have a great day, a great weekend coming, and I guess that would mean towards the end of the year, not the end of the year, but the end of August too, as that's coming soon too. So everybody, again, if you need me, you know where to find me. You can find me here on my blog, Facebook, Twitter, LinkedIn, LiveJournal, and just know my email address, okay? Meanwhile, register with msviewsandnews.org. Have a great day. Bye-bye.
I know the very well respected sites like the MS Society and certain hospital sites that I go to. Those I trust. There's a lot of blogs and other sites where it's just people putting up information, and people, those are the ones you know you've got to be careful about. Doesn't mean that it isn't good information, but chances are there's nothing behind it backing it up.
I like to learn all I can by staying up with the latest publications, and I watch some kind of programs that I can, and I do a lot of reading because there's so much to learn and it changes every day, and I need to stay up on the latest, greatest, because this is my life.
I go to an MS support group and they're always bringing all the new information out, which is great, and it's directly related with the National MS Society, which is a great resource for us to get our information. It's very important for me to try and stay on top of what's going on with the MS world.
Hi, I'm Kate Millikan and welcome to MS Learn Online. Research in MS is progressing at a remarkable rate, with more potential therapies in the pipeline than at any other time in history. Like so many people with MS, I find it important to stay up to date on the latest research and what's happening. Helping all of us to do that is Dr. Brian Weinshenker. Dr. Weinshenker is a professor of neurology at the Mayo Clinic College of Medicine. He is a consultant in neurology and in the Department of Medical Genetics at the Mayo Clinic in Rochester, Minnesota. He is also the winner of the 2011 John Distel Prize for MS Research. Thank you for being here, Dr. Weinshenker.
Thank you.
In the world of MS, there's a lot of excitement because there are a number of oral therapies that are being studied, and one of them is oral teriflunomide. Can you tell us a little bit about that?
Yeah, teriflunomide is a drug actually that is used for rheumatoid arthritis, but is now being applied to MS. And recently, the results of the first phase 3 clinical trial that was conducted over 2 years, the TEMSO trial, have been released, and they showed positive results with a substantial decrease in relapse rate, roughly a 30% decrease, as well as a significant decrease in the proportion of patients worsening on the EDSS, or disability score, that we use as an outcome measure. This was accompanied by also a very dramatic decrease in the number of new MRI lesions. So this is a new drug. It's a pill. It seems to block pyrimidine synthesis. This is an important biochemical reaction that's involved in DNA synthesis and other biochemical reactions, and seems to produce immunomodulation.
Another oral therapy known as BG12 just released findings from a phase 3 study. What are they?
Yes, BG12 is again an oral treatment. This is one that alters cytokine production and changes some adhesion molecules, and it had really quite dramatic results in a study of 1,200 people. There was about a 50% decrease in attacks, which is, in terms of percentage-wise compared to placebo, one of the more impressive results that we've seen of late. Again, decrease in disability accumulation and a substantial decrease in new MRI lesions. So, in a sense, qualitatively similar results to what we've seen with the other agents, but quantitatively seemingly somewhat greater. But I should caution that it's very difficult to compare study to study, because the way patients are recruited and the differences in the placebo rates can significantly alter or influence the percentage decrease. So without a head-to-head trials, it's a little hard to compare one trial to the next.
First results from a large international phase 3 study have come out about laquinimod. What do you know about that?
Yes, laquinimod is a modified drug of another drug that had been studied in MS clinical trials called linamide some years ago, and unfortunately that trial needed to be terminated because of unanticipated side effects. So the drug was re-engineered to make it less toxic. We don't fully understand the mechanism of action, but it seems to produce a shift from more inflammatory to less inflammatory T lymphocytes, make them become Th2. And the phase 3 studies did show again a decrease in attack rate. In this study by about 25% decrease. Again, reduced the worsening of disability that accumulated over the course of the clinical trial. And there was about a 30% reduction in new MRI lesions, either gadolinium enhancing or T2.
How about patients with primary progressive MS? You know, if you have relapsing remitting, there are now so many great treatments here. Are we getting any closer to a treatment for them?
Well, I think we're going to need a new strategy. Our strategy had been that to treat patients with the same drugs that we treat relapsing remitting MS. And in fact, there's pretty good evidence that primary progressive MS really is the same disease. In fact, some of the genetic studies that have looked at genetic variants find exactly the same genetic variants being different in frequency in patients with primary progressive as opposed to relapsing remitting MS. Their MRIs look very similar. It just looks like when we identify these patients, we identify them at a much more advanced point. So I think there are some people who essentially have the relapsing remitting disease, but it's so mild that they never come to clinical attention and never have symptoms, and we don't catch them until they've shifted into this progressive form of MS. We call it primary progressive, but probably a similar kind of disease, but at that point in their illness, it may be that anti-inflammatory drugs that we use to prevent new lesions aren't going to help. By and large, these patients don't accumulate new spots, and they have a number of fixed scars, so the strategy we need is really to repair the nervous system, and I think that's where we see research going. People are interested in remyelination, but the problem is that a lot of the axons have already deteriorated and they may not be amenable to remyelination. People are interested in getting axons to grow, but there are all kinds of technical challenges. Whether drugs that prevent nerves from continuing to deteriorate are going to have a big impact is difficult to say, I think partly because at that point in the disease it usually evolves fairly slowly, and we don't really have very sensitive outcome measures at that point in clinical trials. So I think we're going to need to improve our outcome measures so we can pick up favorable effects when they do occur. And we're also going to need a different line of treatments, ones that aren't entirely anti-inflammatory, or at least not in the same sense that the inflammation occurs in the early course of MS.
What other research is happening for the realm of restoring function?
Restoration of function is certainly a very important issue for a lot of MS patients, the ones we talked about with primary progressive MS, where the amount of new inflammation and new lesion formation seems to be pretty minimal and they have a significant loss of function. Remyelination, I think, is still, for some patients, a viable theory. We're at Mayo Clinic, or my colleague Dr. Moses Rodriguez has a treatment that seems to promote remyelination, and we're hoping that will go into clinical trials. We're going to start it in patients who've had very recent loss of function, say in the context of an attack that doesn't recover, because that's a group of patients we think that may still have axons or nerve fibers that can be remyelinated and allow for return of function. What about those patients who have had substantial loss of those nerve fibers and axons? There's interest in stem cell transplantation, number of technical challenges in, even if one can get those stem cells to grow, making the right kind of connections in the brain and spinal cord so as to restore function. So I see us being a fair ways away. There has been also interest in making the axons work better, and we now have a first approved drug, dalfampridine, which in about a third of patients has a pretty significant effect as far as improving their walking. We don't know about, in the long term, whether making those nerves work harder and harder might, in the long run, cause trouble. This is something that really hasn't been explored. I suppose it's a theoretical concern, but at least for the present time, we do have a drug that for the first time does seem to improve walking, and my experience with a few patients that have noticed clinical improvement, they not only walk better but feel that they have more energy and that they can function better, and it's nice being able to have something that we can offer these patients that improves their function.
You've been involved in a myriad of studies and are doing some incredible things, but I'm curious if there's research that's happening that you're not involved in that excites you, that you'd like to tell us about?
Well, probably one area that I'd highlight is work that's being done to find the cause of MS, and I think one of the most exciting observations lately has been the discovery that Epstein-Barr virus, or the virus that causes mononucleosis, seems to be quite strongly associated with the development of MS. And probably the most dramatic piece of evidence is the fact that patients that have never been exposed to this virus seem almost immune from developing MS or never develop MS. So, and the risk, of course, is small in people that get mononucleosis. The vast majority of people do not develop MS. But it seems that the age at which people develop mononucleosis is also predictive. The later you get it, which tends to be associated with more severe forms of mononucleosis increases the risk. Now, can we prevent mononucleosis? What are we going to be able to do about this? But it does, I think anything that brings us closer to understanding what starts MS may bring us potentially closer to what are the targets that are recognized by the immune system. This, I think, has really catapulted research forward in neuromyelitis optica, an area that I'm interested, because we now for the first time know the target of the immune attack in neuromyelitis optica. It would be nice to get closer to this in MS, because that opens up all kinds of therapeutic possibilities and more specific forms of treatment that can be pursued. So I think the work on Epstein-Barr virus and the fact that it's been now confirmed from so many sources of data is potentially very exciting.
Excellent. Thank you so much, Dr. Weinshenker.
Thank you.
If you'd like to get more information on MS research, go to nationalmssociety.org. This is Kate Millikan for MS Learn Online. Thank you for joining us.